So good morning, everyone. So we're gonna get started. It's 9:05, and today we'll be trying probably something slightly different. We are gonna be talking maybe 30 to 40 minutes. If beyond that, please tell me. And after that, I'm gonna bring three panelists, and I'm gonna ask questions to the panelists because those are the questions I get asked. I usually do not know the answers, so I'm gonna ask them instead. JP Brito, I'm an endocrinologist at Mayo Clinic. I part of the care unit. I will be talking today about the illusion of artificial intelligence in care. I don't have any disclosures, but I do bring a perspective. And I'm saying that because I'm not a machine learning expert. I don't do any coding, but I do AI. And I use AI for research mostly and to fill some practice gaps. I do also research in care and shared decision making and in thyroid. I'm a thyroidologist, so you will see some examples of thyroid here. And also I'm a clinician, so I do see patients and I'm a methodologist. So let me start with introducing Anna. And maybe you have seen Anna in this meeting, and this is a version of Anna. It's not a true version, but it's a version of Anna. So Anna is an 85-year-old woman, originally from Peru, lives in the United States. She speaks only Spanish, and the only person that she can speak with is her son. She has diabetes, chronic kidney disease, dyslipidemia, hypertension. And you can see Anna looking at her medicines, looking at her coffee, after she received a phone call from the primary care office saying that that tiny nodule that was found in the CAT scan of her neck because of back pain actually is thyroid cancer. So what is the role of artificial intelligence for somebody like Anna? And the question is pertinent because AI has permeated pretty much every aspect of our lives. So the reason of whether AI exists or where it is, I think we have been using AI quite a long time. I haven't seen these cars here, but if you go to San Francisco, you go to San Diego, there's everywhere the driverless car. So there's everywhere. If you came to your airport, you will see that you get to scan your face, so that's facial recognition being used all over the world. And we have been using SPAN for a long time as well, and SPAN is a form of AI. But we are now using AI in many of our clinical encounters in the form of AI scribes. What they do is they record encounters, they transcribe it, they summarize it as a way to avoid the typical summarization or clinical note typing that the clinicians do. And beyond that, I think anybody has been very impressed with the results of AI in medical tasks. So here to the right, you can see a line that reflects the performance of different models in answering questions, medical questions, back in just a few years ago. They were not performing that well, not enough to pass those medical tests. And these are the medical tests that every physician in the United States needs to take to be certified as a physician. As you can see over time, the performance increased to the point that overpassed already the performance of clinicians. So it's performing much better in medical questions, answers, than the physicians do. It's not only that. I think everybody now probably has seen the papers in which they can indeed diagnose or have a differential diagnosis better than us. And this has sparked a lot of interest from the leaders in the technological world, the people who is bringing up this computer, the people who is going to take us to Mars, apparently, and the people who actually give us those cars. So on the right upper panel, you have what has been called the father of artificial intelligence, Geoffrey Hinton, saying in 2016 that if you are thinking about studying radiology, you think otherwise, because we are not going to need radiologists in the future. Bill Gates says that AI will replace doctors, teachers in 10 years. Elon Musk says that AI is already better than doctors and we will not have a job in the future, similar to Sam Altman, the president and CEO of OpenAI. And this has been captured in the media quite a bit, and probably you have seen that, some of those outlets. And this is not a theoretical thing anymore. And remember, these are people that have money, and if they believe something, they will put money on that. It's not just rhetoric. It's really things that they want to invest on. And there are millions now of these platforms, well, not millions, but many platforms, particularly in healthcare and in mental health. This is an example in thyroid, in which this platform already exists, that you get access to this platform is a chatbot You get asked questions, and after the questions, you can be prescribed medications, and you can also be prescribed or ordered thyroid ultrasounds independently from a physician. And I believe that what is behind this is what they think is something like this, that reaching replacement is just a matter of a function of time. That maybe we already have it now, but if not, it's just going to be a matter of a few more years, passing some years, or just architecture, that we will improve it in a way of more data or different complexity of architectures that will get us from assisting roles, from augmenting to replacement. And I would like to postulate that that is a misrepresentation, that is no more than an illusion. And here I will be presenting 4 of those, there are more, and for which I believe that they are not getting it right. They think that we can predict the future. I think they think that we have the right data and the technology. I think they believe what care is. And probably the saddest one is that I think everybody believes that developing AI medicine is about patient well-being. Why am I thinking that predicting the future is an illusion? Because predicting the future is extremely hard. Otherwise, open your phones, get the weather. By now, we should be able to predict the weather very well. And who really trusts the weather, other than just 10 minutes when it's raining? Predictions more than 10 minutes is complicated. Predicting the future in 60, 90 minutes is even more complicated, not even a week. And you might remember COVID. COVID had a humongous amount of data. And during COVID, many AI models were developed. And I don't think you have ever seen a model that survived, or I don't think any of us has seen a model that survived the era of COVID until now. So many of the models did not have a good prediction. They made a lot of mistakes. And on top of that, they have a lot of bias. So they did not survive even in the time when we were collecting a huge amount of data. And this is just some examples, but this is quite famous, the EPIC sepsis model. This was advertised by EPIC. EPIC is the EHR system that probably is used 70% of the United States using this system. So EPIC, having a lot of data, developed a model that predicted the chances for somebody to get sick and needing ICU. And that's very important because in sepsis, if you predict who's going to get sick, treatment makes a huge difference. And EPIC, when they developed the tool, they forecasted that the AUC, which is the area under the curve, is a way to distinguish between true patients getting sick and not getting sick. It was 0.83, which is quite decent for a model. And this was not only implemented, but widely used in 100,000 patients in the last years, until independent group actually validated, and they noticed that the performance was no better than flipping of the coin. And they have to retract it, showing that predicting even biological events is extremely difficult. But even something like that has been attempted, predicting who is going to commit suicide. And this is more behavioral, difficult outcomes to predict, but we have tried, people have tried, and of course, as expected, they are not better than humans. What tends to happen is that the models perform really well in the data that we develop and test. Once we validate it and we put it to the test in a different setting, they failed. And one might say, but we can predict the future, and that's true, but we predict this kind of future. We can know exactly where the Earth is going to be in the next hour, the next second, because this is a physical laws. And I think they are confusing that with predicting behavioral stuff or predicting humans. This is governed by laws in which more data narrows the prediction in a way that is better. More data is actually good. But humans, at least no one that I know, is governed by any physical laws. We are, by nature, unpredictable. We're complex. We are contextual. We're self-aware. For somebody like Anna, for instance, can we predict her next move? She will decide to treat or not her thyroid cancer. The other assumption is that we already have the right data and the technology to care. This is a picture, courtesy of David here, that shows in a shape of a body where the data is coming from when we think about ChatGPT. This is ChatGPT, old ChatGPT version 3, but it's difficult to get exactly what data they're using now, but this is what they were using back then. And as you can see in this model, the blue part is the data that comes from pretty much the internet. And in the red is Reddit. So think about this. Think about the models that we think about using in medicine, being trained in conversations about vaccines, or being trained about conversations about COVID treatment. Think about how much data is run in the internet, and we're using this to train the models that we think are going to be useful in care. We will never ask medical students to go to Reddit, to read Reddit, and take care of a patient that's dying. We will never dare to do that. And to be fair, I think the field has realized that internet is not ideal for medical tasks, and they are tuning the models listed here in medical data. And what they call medical data is not other than EPIC. EPIC is what we have in terms of documentation. But everybody who has taken care of a patient knows that this is no longer about care. This is about documenting enough so we can bill the patient accordingly. So again, nobody will dare to send a medical student to read EPIC before they take care of patients. And the architecture of these things, while fascinating, I think David presented this yesterday, and this is a slide also from him, shows how they work. In simple terms, you have a sentence in the top. The words get pretty much assigned a number. Based on that number, they get assigned what is called a vector, and if the words are similar, the machine will understand what they kind of represent, and by virtue of that and being trained on a massive amount of data, the sentence, for instance here, enlarged lymph node with increased vascularity suggests they are able to tell with some accuracy that the most likely next word is recurrence rather than a cat. So they know that because of probabilistic things, recurrence is what follows. But can we actually think that a system that predicts the next word is able to reason, who is able to understand human emotion? So the argument here is that they do, but I find it extremely difficult to understand that. So they have worked on what is called reinforcement learning, which means that I think the understanding that predicting the next word doesn't align with values of patients. What they do is they prompt the systems, and depending on the answer, the users might say, I prefer this answer than the other answer. And if you do that thousands of times, the system will learn what we appreciate or we prefer as humans. And I find it that while it's a trick, I find it quite interesting in care. Because care is not about making the user happy. It's sometimes having difficult conversations, even though we disagree. So there is a question here. I prompted ChatGPT, again, a title question. It's somebody that was asking ChatGPT about trimming when they don't need it. So normal title function requesting trimming. Everybody will agree those conversations are difficult. They are real. There are patients who are coming asking for treatment when they don't need it. Those take time. They require relationship. They require trust. After 3 prompts, ChatGPT was giving me not just 1, but 2 hormones. And they were saying that they were acknowledging that while they think we don't have the disease, I think the treatment is beneficial. Again, it's user experience, what they are aiming at. And this was just published last week, and this is perhaps one of many future papers that are going to be in the field right now. It's a paper in which they remember the medical questions that they got to write. So these actually ask the questions in a different way. They didn't ask the answer, but they asked them to reason why the answer was like this. And they completely failed. So they are getting the questions and answers right, but they do not know why. So that is the trick behind these tools. For Anna, we might be able to know her genome, her labs, even their notes. Even if we put trackers in her home, we might know her behavioral history. But do we really understand how she feels? Only humans can understand what could be to receive the news of cancer. Because we understand sadness, we understand isolation, we understand that maybe she feels lonely right now. Because caring is experiential, and machines have not experienced that. The other assumption here, a misinterpretation, is that they know what care is and they can actually compute it. And when this happens, I think I understand what they meant when they say care, because they reduce care to task. So care is such a complex thing, but they reduce it to task. And from the task that they chose knowledge transfer. Because you can actually compute the amount of knowledge that comes from somebody that knows better here, the assumption, to somebody that knows not enough. So they reduce knowledge, reduce care, to something that they can compute. And they go with care is about knowing what is best. And you can start seeing a lot of these papers of people not knowing whether the question comes from the computer or from the humans. And by virtue of the quality of the content, understanding that now the responses that come from the AI are so good or even better than the ones from humans, because the content might have enough knowledge. And maybe they're even more empathic, like the one study there, that you can see the distribution of how patients or people might prefer the responses from AI because they're more empathic. What I think is happening, I don't think they are talking about care, they're thinking about care with K. Knowledge alignment repackaged elegantly, pretty much saying the right things nicely. Until now, nobody of the AI community or even people working in the field, or maybe you have also noticed, they have not knocked your door and said, can I watch how you take care of patients? Let me learn from you. Because the interaction is when care happens, but nobody dares to go there and learn from the clinicians and patients anymore. And as you can see yesterday, defining care is extremely difficult. And I actually think that we shouldn't dare even to define care. It's a multidimensional, I wouldn't say task, but process. Similar to whether we dare to define love. And if we think the analogy of love, we will never think that we can compute love. We will never think that we can make 1 and zeros from love. But I think the field is trying to make 1 and zeros from care. Care is not just about knowing what to do, it's connecting and relational work. And the last one is the incentive of develop AI in medicine is patient well-being. And this is not an issue of AI, it's pretty much an issue of the culture and context where we practice. This is a process that is a process in how the incentives to some extent had changed over time, developed by Victor. At the beginning, care probably was more relational, so doctors were going to your homes, they knew your family, they knew you from the beginning, and they kind of developed this relationship over years. So the doctor visiting the family, a friend stayed at home, have lunch. Then develop the cures for many of the problems, but the cures require equipment, require machines, so we can no longer go to patients' homes. They need to come to us. And we develop the buildings, we develop the healthcare system. But guess what? Those machines are expensive. Somebody has to pay for them. So who can pay for them? The patients. So we needed more patients, we needed volume. Now the incentive is no longer the patient, it turned to keeping the machines alive. Now it's really trying to get as much as we can from patients, financially. So now it's about efficiency, the processing of patients, what Victor called industrialized healthcare. And lately, pretty much boosted by AI, I think in the data-fied healthcare, where we realize that we can just get as much money from the patient as long as they stay in the hospital. But guess what? The data can live forever. we can extract as much data from patients and we can profit from it. And I think the system now, incentivized, of course, from relational to data, has the potential to corrupt tools that we develop in healthcare. So think about the AI scribes again. Very well intentioned, I believe. So the idea was that we were going to help the doctors in administrative tasks. And I do really believe that they had all the good intentions in doing so. But as the thing progressed and been implemented in a system that has been industrialized or datafied, it's very clear how these tools now are being corrupted. So if the idea was to help clinicians have more time, guess what? The time has to be filled out. There is not enough, too many patients for you to have enough of free time. Even now, this is free in your time, you have to see more patients. And now the tools are turning into what is called billing tools. So they are able to extract information from the encounters for which they can bill higher. The companies will pursue that as the main outcome of the task, rather than really summarizing the encounter. And now you see what's happening. I'm not sure you already experienced that. For different practices that have that, they are telling the clinicians if they want to use AI scribes, well, they have to add one or more patients to the morning routine. And the problem here is that the ecosystem in which we practice perpetuates this. So think about this. We're processing patients, we're getting the data, we're developing AI systems that the goal, while well-intended, might be patient well-being, but is corrupted to a more efficient and efficiency angle. That will continue to boost industrialized care and will continue to boost data-fied healthcare. And guess what? The future of AI tools is going to be the AI tools of the past. So the future AI systems are going to be trained in AI systems that actually produce the documentation that were meant to improve at the beginning of patient well-being, but now it's about efficiency. So the loop of efficiency gets worse. But care is not about really shortcuts. It's not about the minimal effort. Actually, care requires effort. And the systems are supposed to save time, being efficient, while care is not efficient. It's about really investing even beyond any outcome. And while we don't see fully right now, I do see that harms are coming from this rhetoric. I think the erosion of skills, roles, and relationships are at stake here. And I think that we are seeing the perspective of patients in the relationship, but what about us, the clinician? The reason why we exist is to care for patients. And every time that we care for patients, caring actually reshapes us. So what is going to be of us if we are replaced? And the next steps, I think the more important one, is a lot of humility. To understand that numbers do not really care, that care is human. And not now, but ever. It's not an issue of the current technology, it's an issue of this is a human endeavor. But I'm not naive. I think there is a role of artificial intelligence, but the way of thinking about the role probably makes a huge difference. So Victor developed this model, which I think is very helpful in understanding where AI can exist. So think about perhaps two roles of caring for patients. One is the fixing of the cure in the bottom that has to do with the right answer. If you come with a fracture, where the right answer is to fix the fracture. If you come with an issue, your eye that we were talking yesterday, well, the issue might be quick, might be a fixing test, or a fixing procedure. It has required a right diagnosis, right technique. Nobody will disagree. Nobody has or needs a good relationship with their clinicians just because they need something fixed. But the rest, which is the vast majority, will require care, will require managing the symptoms, longitudinal care, relational care. If we think about this, now we can start thinking perhaps some roles of artificial intelligence in care. Thinking about that in the fixing part of things. AI actually might be welcome because, again, we have the right answer, we have the right procedure. In the care part of things, in the chronic condition management, for instance, we shouldn't ask AI to replace us, but AI can help us. Our group, developed over the last 2 years, has been working on this, but mostly focusing on AI where it is best, which is research. So you probably have heard many of these projects all over this conference, but we think that the most important way of developing AI is by looking at interaction. So internet data, not enough, Reddit, not enough, Epic, not enough. You really want to understand how interaction happens. So Paul, yesterday expanded quite a bit of work in encounter data. I think that is the right way of doing it. We are expanding this as well, capturing this data, understanding the insights of interaction to develop AI that really gets it, at least to some extent. Developing perhaps systems that help us measure shared decision making. This is work of Dr. Ponce Ponte, in which capturing signals from the encounter, we can, to some extent, measure surrogates of shared decision making that help us understand in the big picture, perhaps people going or not going through shared decision making, understand distributions, and improve interventions. Developing tools that really have a patient-centered perspective. So what about the summaries that we were talking about from the AI scribes? They are for clinicians. What about summaries for patients? So this is work in developing those summaries for patients and being able to develop models that perform that. Our group is also working in markers of attention in the encounters. So what about gaze? Not just because gaze is important, but because gaze where the gaze attention is might provide an interesting signal to understand this. So I also find many of the encounters that sadly the clinician spends more time looking at the screen than looking at patient. So what is the effect of that? And if so, for instance, what is the effect of AI scribes in more gaze attention to the patient? And I will assume that they should have an effect, because if we have a machine that's summarizing things for us, we should stop typing while the patient is talking. We should start seeing the patients. And when I told you that I will not dare that prediction is wrong or bad or difficult, I'm gonna dare to predict the future. So there is an interesting effect when technology is implemented. Sometimes jobs are lost, but sometimes the opposite happens. Automatic bank tellers, the ATMs, came for first time in the 60s. And everybody thought that the bank tellers will disappear, because now you have a machine that gives you the money. Why you will need a human being? Guess what? After they were implemented, people realized that banking was not that bad. It's better to put money in the bank than keep it under the mattress. And the bank tellers as a profession actually continue to increase. And it's very important because you became more relational to some extent. People start getting to know the bank tellers a little bit more. I think that's going to be the future, at least the future I want to believe on. That the AI will take care of many administrative things. And the relational one will require more clinicians, will require more caring. So I'm very optimistic that that will happen. And with that, I appreciate your time, and I will bring my panelists, David, Bram, and Victor, to the front. Thank you. And to start with, I will ask you just to give you a one-sentence introduction, so just understand a little bit of the background. And then I will, please feel free to ask. I will start with the questions just to start things going, but then I wanted to make it interactive as much as possible. So Victor, I think everybody knows you, but one sentence.
Victor, endocrinologist and a friend of Juan Pablo.
Yeah, good, good.
Endocrinologist as well. I work with this too.
Bram?
I'm Dijk. I work for the Leiden University Medical Center, and I don't collaborate yet with So again, everybody is welcome to ask questions, but I'm going to start this rolling. And
one of the things that we keep hearing in the field is that when I'm presenting, for instance, misses an important point. That is that humans will be always in the loop, and that humans will be there to care for mistakes of the AI system. So, Victor, what are your thoughts about having humans in the loop as a way of making the system safe?
Yeah, I think the metaphor is used often to describe how the world prevented nuclear war. There was a system that detected that the U.S. had fired missiles with nuclear warheads into the USSR, and the signal was supposed to then generate a response from the USSR sending nuclear warheads in missiles to the United States. But they had introduced a system where a human had to finally authorize that system to fire. And that general basically said, I'm not going to fire those missiles back. And it turned out the signal was a mistake. And if that general had not been there, the missiles would have been fired, and we would have had nuclear disaster. And so engineers have thought, well, there's always keep that human in that loop to prevent disasters. So first of all, I think it suggests that you know that your system is prone to disasters, right? So if people that develop AI systems say, well, we should always keep a human in the loop, they're basically telling us something that we seem to resist, which is that we shouldn't trust these systems because they can produce disasters. The second thing that they do is that they assume, like that general, that human has the ability to identify the situation, read it quickly, and has the discretion to override the machine, to override the signal. But you can imagine being that Russian general, if he had been wrong, right? If he had been wrong, in other words, if he had not fired, if he had ignored the signal, there would not have been the opportunity to retaliate, which I think is generally a good thing, but from a maybe Russian perspective, not so cool. And so and I always tell this story that Victor and I actually experienced together. We went to see a football game in St. Paul, which is about an hour north of Rochester, Minnesota, where we live. And as we were driving back, Victor was driving, and he had programmed the navigation system to get us back to our home. And the navigation system gave this weird instruction to actually not get on the highway that directly gets us to Rochester, but for some reason to go outside that highway into just the general streets of St. Paul to eventually meet the highway way over there. And as the navigation was indicating that, I told Victor to ignore it. No, just get on the highway. I know the answer. Get on the highway. And Victor was like, I know the answer too, but the system must know something we don't, so we should. And we were approaching the point where the road divided, and we were just approaching that, and I get it, no, what to do? And eventually he chose to go out because, the idea was, normally we would do that, but this is so strange that the machine must know something we don't know. And so we were stuck in traffic for a little longer before we could get on the highway. That was relatively inconsequential, but having the human in the loop, two humans in the loop, was actually insufficient to override a system, because at the end of the day, we thought the system must be computing something that we just are not computing ourselves. And can you imagine if the computer, in a situation of an intensive care unit or other things, tells you to do something for a patient, and you override it, and then the patient has a bad outcome? What is your legal situation? But more importantly, what is how you feel as a human? So the prevention of feeling so bad after overriding a system that is smarter than and more empathic than humans will probably make most humans in the loop unable to override it. And then the third thing is that the reason to have humans in the loop is that eventually that human is going to have to absorb the consequences of whatever decision the machine with the human are making together. And so for a developer, and for a purchaser or buyer of that technology in a hospital, for instance, to say, Dr. Toro is going to be eventually responsible for this, means that I don't have to do that much due diligence to make sure that the system is safe. I can be the first hospital in my area to have this brand new system, and if it's not totally safe, I know Dr. Toro is there to save our patients, and if he doesn't, I know he will take responsibility for it. And so that reduces my responsibility as a leader, but also reduces the responsibility of the software. And it's Dr. Toro who will have to live with the consequences. So he becomes the moral absorber of all the failings of that system. So the idea that we are better off by having systems that design a human to stay in the loop is, I think, a trap.
Yep, I completely agree. So the reason why I bring this question up is because you keep hearing in the healthcare system where we practice that as long as we are there, the system will be fine. But I don't think the people in the loop are asked whether they're going to be part of the loop. David, tricky question. You have been asked previously this, and I'm going to ask you again. Another argument of why the role of AI in care and replacing us might be correct is that it might be better than nothing. So think about those individuals, those patients, those humans that they don't have a doctor or they will not see a doctor for 6-12 months. At least they have ChatGPT. So what do you think about it?
I don't agree, actually. It's a fundamentally wrong concept because it perpetuates inequality. You're not fixing the problem, you're just putting patches to the problem. Mm-hmm. I think there's two sides to this equation. I see a lot of people that say, let's develop tools so that we can bring specialized care to places that don't have it. I see people thinking, let's develop tools so that we can bring special pathology interpretation to places in South America. Great. If it's a specialized tool that is regulated, that we can trust on, phenomenal. But if we're talking about let's just bring general purpose technologies that have not been developed for healthcare and have not been validated for healthcare, and it's just patients using them on their own or guided by healthcare providers, because I have actually run into a lot of people, for example, in South America, clinicians that are advising diabetes-related care or thyroid nodule interpretation or CGM report interpretation and treating their patients with ChatGPT. To me, that is unacceptable. Even if it's the only thing they have available, that is unacceptable. You are exposing the patient to risks. You have the potential to cause harm. So this is not the solution. This is not the way to approach things. And you're potentially exposing your patient to harm, which is one of the things we should not be doing in our profession.
Yep. Bram, I have a question that has to do with the architecture of these models. So I'm making the case here, and again, it's my personal, to some extent, opinion, that the architecture of the models right now don't really reason to the point of them being able to understand things. I have seen different experts arguing against this. What are your thoughts, and if so, if yes or not, what is the next step, for instance, for these architectures and tasks as complex as care?
Yeah, so some of the recent developments, so before we actually had language models, and for example, when we asked them a question, we could ask them very explicitly to think carefully about the problem, right? And this improved performance for some, language-specific tasks. And the current reasoning models, they seem to have this recurrence property where they see their output and they try to refine iteratively this output before they actually give you an answer in return. And it turns out that very often, also for quite, relatively simplistic problems such as integer addition, the reasoning is very, very hard to follow.
it doesn't mimic human reasoning, for example. And there are indeed philosophical discussions about the issue. So suppose that the output that we get is correct, but we cannot understand its reasoning. Can we then say by definition that this model has no cognitive capacities, or should we care more about the correct answer under the assumption that it is correct, or should we care about the way that this model comes to an answer? Maybe it has a different form of cognition, right, that we don't fully understand. Maybe we cannot make fully sense of it. I think that this is something that we currently don't understand fully, and also don't have solved fully. And yeah, so for me, the real value, and also the thing that we will have to work with, is in the quality of the answer to some problem that we ask the model. And I like always to play a little bit devil's advocate, but I was intrigued by your remark that there's very little law in the social world, right? And to some extent, I totally agree, because humans are unpredictable, but at the same time, humans behave very predictably. I mean, these people have been sitting around for quite some time, and they are listening or pretending to be listening, and nobody starts throwing a laptop at me because I'm saying weird things.
It's coming.
But you know, the thing is, I'm constantly making inferences about what happens internally, and I may be totally wrong about how these people, you know, manifest their observable behaviors. I'm making an inference about these behaviors, and I don't have all the details about the way that they are reasoning or how they are internally constituted and so on, but what I care about currently is what I can infer from what I see. And I can base my future actions on that. So with all of these questions, I think that we shouldn't presume that, you know, for humans we have all these questions about their cognition, their rationality and so on fully solved. And I think that in Marika Adriaans's talk there was also a little bit of discussion on that we maybe doctors not in all situations are as rational as we hope them to be, for example. And of course, saying that humans have biases and that therefore we should accept biases in language models or whatever, it's a really bad argument. But I think that it places the discussion a bit more in context.
Yeah, that's a good thought. Questions from the audience? Yeah, do we have mic?
You have mics? Yes, but
Yeah, but the online people can't hear if we don't do it on the mic, so.
yeah, the world is listening. So.
Yeah, I don't think I see it.
They're over there.
Cheeseburger.
Here you want to take this one. It's not on.
Hi, Sonia, and I'm a Canadian. An excellent presentation and discussion. I wanted to actually ask your thoughts on ethics. So a year ago, I just looked it up. Out of the training hospital where I trained, now I've moved, they ended up publishing a paper on ChartWatch, which monitored the electronic EMR and could actually predict death to signal the team that there is a predicted death in the next 48 hours, please reassess, and so forth. And using this, they reduced mortality by 25%. That's incredible. That's a hard outcome. I was curious about the ethics with this being at an academic hospital, but if you're 40 minutes away, that you would not benefit from this in a community hospital. Nor do I foresee this coming in the next 5-10 years, where those community hospitals have invested in other EMRs and so forth. So just your thoughts about equity when it comes to tools, whether we should use them or not, but just perhaps that.
Absolutely. I can start with something and then anybody in the panel can continue. So I find these problems very similar to what has been mentioned before, that because we can predict, it doesn't mean that we should predict. there was a beautiful slide that because there is a nail, everything becomes a hammer, and for us it's like that. The suicide model, for instance, I presented brings the same questions. So in those models, many clinicians were alerted that patients might be suicidal. And they trigger actually reaching out to those individuals who are already very depressed to tell them, by the way, the AI is telling me that you are maybe kind of suicidal. So imagine the complexity of those and being based on misclassification. Many patients were alerted and clinicians were alerted when they shouldn't. And those were actually shut down. Those systems were shut down. So going to your point, and going to even conversations that happened yesterday, we have to be very careful about even thinking how things are going to be used before we ever develop them. I'm not sure if the panel wants to.
I only have a point that there is a whole press release-based medicine going on where a lot of institutions want to be first and want to be on top, and they want to hype their findings. Many of the prediction, as you said, with COVID, many of the prediction tools have not, there's 4 stages of a prediction model in terms of the evidence. The last one being where you randomly assign care where you're informed by the prediction versus care where you don't have access to the prediction to actually see what the effect is on outcomes. And most of the time, those types of trials, I mean, those are very rare. And so as a result, the quality of the answer that we have from the evidence about prediction is usually, and I'm not talking just AI, I'm talking about prediction in general, from just basic statistical prediction all the way to AI black box prediction, the quality of the evidence is usually much lower. The other thing that prediction assumes is that there will be an appropriate response that would change the outcome. So if I announce that there will be, that David is at risk of dying in the next hour, the question is, what is a response to that information that would actually have a chance to change that outcome? And it's possible that there's nothing we can do. We just alert David's family so that they can be with him. That would be nice. That probably would be one of the most caring things that we could do. But you can also imagine the system just revving up and intensifying the technical care of David, because we have to now we've been alerted. How can we just sit there and do nothing and just call his family? So what are the triggers, and would those triggers actually do more good than harm? So it's not enough to be able to predict. We also have to know that the answer to that prediction will actually do more good than harm, and that requires a clinical trial.
I think I would like to add, I think part of the challenge is within this moment in time in which the technology is not that it's new, the technology has been present for decades, but it democratized. It became widely available to the public. And by being this very rapid growth, such a short time frame, and healthcare systems heavily investing on it, there's this big push to have results. And this has created the fake illusion that this is ready for daily use, which I don't think it is. But there is pressure for it to be. And part of the problem is that this has skipped a lot of phases in the development of these tools. And I think now is the time to make a pause and say, the fact that we can do it does not necessarily mean we should. There's a ton of things we can, but maybe we don't need to. So, for instance, in the clinic, I feel like sometimes we have a lot of projects in which we are being pushed to include AI in the methods, even if it's not needed at all, because we can just use traditional stats, you know? Just because having AI makes it like nicer or more fundable or things like that. But again, that doesn't mean you need it. So it's this moment to say, like, do we need it? Do we not need it? So first, a point there. Second point, we need to really think about putting the patient and the clinician at the center again. There's a lot of teams just developing ideas, and once the idea is developed, then we throw it at the clinician and the patient and see how it works. And then we realize there's no use for it, and then it all goes to the trash. All of those resources, all those trees, all that water is gone and completely useless. and we're going back again at the drawing board. So having the patient and the clinician and all the stakeholders involved from the very beginning, you shouldn't start coding at all until you fully understand where is it that your tool is going to be working, what is it that you need, what is it that's going to be the plan after you have the results. And I feel like most of the tools that are being developed have no idea of any of this until the very last moment when the tool is almost fully developed. And then they have to pretty much do everything all over again. So that's a big problem. And I guess now there's a big push for two things, which is like explainability. Try to make these tools as explainable as possible within the limitations of the methodologies, which is tricky, and bias and fairness. And there's, I guess we all realize that the training data has its limitations because we're pretty much looking, this is a mirror to the past. AI, people think we're looking at the future, we're looking at the past, try to predict the future with the past. So we have to be very careful about what is it that we're using because we don't want to mimic all the biases from the past. So doing a very fair audit of all that bias from our data and making sure that we're not perpetuating that, completely important. And that's one of the big challenges, for example, that we have at Mayo with our data. We have a predominantly white population. So we want to make sure that whatever we do is something that we can actually take out of Mayo. So just some things to keep in mind.
Thank you, David. Bram, do you have anything to add? Or?
Yeah, so rightly so, we are very critical of this everything AI perspective, right? Also because that's often not the perspective of actual practitioners in the clinic. So I think that a lot of the ethical issues, and it's not only about, do we represent the entire population, it's also about environmental issues, right? What about energy consumption? What about the people that are actually labeling the data, right? They are often invisible, but there are very dodgy practices in getting the data labeled to low-income countries where there are specific agencies that are asking people to label horrific content without proper guidance and care afterwards. But I think that once you let go of this issue that, we can compute care or we can define care or we can let, for example, the companies that spend a lot of money on building these models decide what problems we will solve. We can actually go into the clinic and ask, so in our case, for example, a geriatric specialist, what problem could we, or what do you experience and what could we do in this context with an AI tool? And that doesn't mean that you replace an entire consultation, but for example, that the problem is very well defined. So currently we are struggling getting all our prompts filled out by our older patients, for example. Could we think of a way to have a conversation about topics in these prompts? We don't ask the model to come with a diagnosis or whatever. No, we just want to have this conversation and we want to have a summary of this conversation. And we don't want to develop this without these stakeholders. So in every phase we will ask them, what do you think about the tone of the conversation? What do you think about the interface? Is the information that we are getting useful at all? And if it's not, then we go back and redesign what we built initially. And only in this way, I think we can build AI that solves a meaningful problem and that has a chance of actually being deployed, because a lot of these innovations, they don't make it beyond the prototype phase. At least that's the case in the Netherlands.
There is a sense in the general population and in some healthcare leaders that we are great in healthcare, that we are going to be super careful in our use of technology, and all this is just, fear-mongering, because we're super smart. And then you look at the use of surgical robots. And, for instance, for doing hysterectomies, right? Taking women's uterus out, which in many, many cases is a completely unnecessary procedure, but say that it becomes necessary. The patient is presented with the idea that the surgeon will use a robot and they will only, I mean, it would just be like minimal incisions, maybe like 5 different ones, so they can put all the robot parts inside your body, and then they will take your uterus out, and then you'll go home the next day and it will be lovely. And I have a colleague that goes, I can do that procedure vaginally, and there'll be 0 incisions, and the person will go home the same exact day. So why are all my trainees now for, over the last 10 years being trained on only doing that operation using the robot? Why are rural hospitals now obligated to buy the robot because their surgeons can only do the operation with a robot? And where we're selling 5 incisions instead of 0 visible ones. And there's no value, but it's robotic. And I think we've done this in healthcare, we've done this globally. We've done this at scale. We've made this massive mistake. Pulmonary surgeons are doing lobectomies that they don't need a robot to do. People are doing robotic surgeries that actually have no particular value to the robotic. There's more waste. Environmentally, they're horrible. And you have to do enough to actually pay for the darn thing because it's a subscription model, like some of the worst apps that we have. And so don't tell me that we haven't done this before. Now, we do this again and again and again because of a failure of moral leadership that is based on care. And we just decide that it's better to think of moral leadership based on efficiency, productivity, convenience, marketing. We know better. We should have moral leadership based on care.
Well, I have to say thank you to the panel, and thank you everyone for your attention. I do believe this is an opportunity for our field, our group, to trying to mark the agenda of what would be an alternative of medicine in which AI is used in a good way, no? Casey, do we